Well, welcome everyone to today's Clinician Executives webinar. Our topic is Finance Fundamentals for Clinician Executives, Building Confidence in Financial Decision Making. I'm Bruce Lloyd, ACHE of Georgia's Executive Director, and pleased to have this webinar. We've got a great attendance today. Really looking forward to it. I'd like to start our meeting just by recognizing our annual sponsors. Our platinum sponsors are Emory Healthcare. They're a brand new platinum sponsor, so welcome to Emory Healthcare. City of Hope Cancer Center of Atlanta, Grady, Kaiser Permanente, Moss Adams, and WellStar. Our gold sponsors are Act Talent, Atrium Health Navicent, Encompass Health, Grant Thornton, Healthcare Program Advisors, Northeast Georgia Health System, Piedmont Healthcare, Scale Health Tech, and Vizia Technologies. And our silver sponsors are DT Spade, Georgia Nurses Association, Metro Atlanta Ambulance Service, HWL, Premier Federal, SSR, and Biblio Health. Okay, here's our upcoming events. We've got a lot of things going on. I'm not going to read all this, but just wanted to highlight that on August 7th, we're doing our networking night across Georgia again, and we're going to have networking events in Atlanta, Athens, and Augusta. And the Atlanta event we're doing with Bonfire Atlanta, so that should be a lot of fun. Our next Lunch and Learn is going to be at Maggiano's on August 21st, and we plan to open registration for that soon. And our next Clinician Executive webinar will be on September 23rd, and that session is going to focus on process improvement. And you can register for all of our events at acheofgeorgia.org. This fall, ACHE Georgia is offering two $2,500 academic scholarships to student members in our chapter who are pursuing a healthcare-focused master's degree. Be sure to apply by September 5th. And congratulations to our new fellows. This is great news. We have 16 new fellows so far this year. And we just finished a big Board of Governors class a couple of weeks ago, and we had 94 signed up for that. So we're hoping that a lot of those people will take their exam, and we'll have even more new fellows by the end of the year. Okay, today's program offers 1.5 hours of ACHE qualifying education credits. When we're done today, go onto the ACHE website and you can self-report those credits in the My ACHE section of the website. Okay, at this point, I'm going to turn the meeting over to Jennifer Giusti. She's a FACHE. She's Chief Executive Officer at Just Performance and an ACHE of Georgia board member. And she's also the Clinician Executive Committee Chair. Jen, you want to go ahead and introduce Felix?
Absolutely. Good afternoon, everyone, and thank you for joining. Before I introduce Felix, I do just want to sort of underline an announcement around our clinician executive webinars. So that next webinar is Achieving Excellence, Process Improvement Philosophies and Methods for Healthcare Leaders, and that's September 23rd at 11:30. It's 11:30 to 1 p.m. virtual. It's the third in our series of four. So really encourage you to register for that as well. And we also offer a registration for all four sessions in the series. The first three are virtual. The fourth is going to be a lot of fun. It's called the Executive Edge: Networking, Presence, and Servant Leadership for Healthcare Leaders. That's on November 19th. That'll be in the late afternoon, evening. It's in person, going to be kind of a fireside chat format, and then some socializing afterwards with appetizers and drinks. If you would like to register for the four-part series, it's not too late. Go ahead and register. I think Bruce is going to drop that link in the chat, and you will receive the recordings for the prior sessions that you may have missed. So really encourage folks to take advantage of that. So with that, I will move on to introducing Felix. So originally from Lima, Peru, Felix Soto graduated from the University of Ricardo Palma School of Economics with a bachelor's degree in accounting and a CPA license. In 2000, Mr. Soto moved to the United States to pursue graduate studies, and he obtained an MBA with a concentration in finance. Mr. Soto is the Chief Financial Officer at WellStar Cobb Hospital and a Vice President of WellStar Health System. The hospital serves Cobb County communities and surrounding towns, and he's served in this role since 2017. Before working at WellStar Cobb Hospital, Felix spent 6 years as the CFO at WellStar North Fulton Hospital, and prior to that, he was in California for more than 10 years, where he worked for Tenet Healthcare in multiple leadership roles, including a CFO, controller, and CFO. In total, Felix has an impressive more than 24 years of leadership experience in the healthcare industry, and he's a transformational leader with passion for serving the community, and I can attest to that. I've known Felix for a number of years now. Felix is also a board member of ACHE of Georgia, where he serves as the treasurer, and he's a board member of Partners Cooperative, Inc., which is a not-for-profit support services company serving 501c3 not-for-profit hospitals, governmental authority hospitals, and university-based academic health systems. Felix and his wife Anka and their 3 daughters, Rihanna, Alyssa, and Esther, live in Peachtree Corners, and they have a really interesting multicultural background, as Anka is originally from Romania, so they all speak Castellano or Spanish, English, and Romanian. In his free time, Felix enjoys spending time with his family and exercising, and he holds a black belt from the International Shotokan Karate Federation. And we're so thrilled that Felix was able to carve out the time to spend with us today. So with that, Felix, I'm going to hand it off to you.
You're on mute, Felix.
Can you guys hear me okay?
Yep,
All
we
right.
can.
All right, let me try to share my screen, and hello, everyone. Bruce, can you confirm if you can see my screen?
Yeah, this is the split screen right now.
All right, split screen. So how about now?
That's great.
All right, terrific. So, all right, so we'll get it started. So the agenda for today is going to be about understanding the why behind healthcare for clinical leaders. So hopefully we have a bunch of clinical leaders in the room, because this is intended for you. If you have accountant, financial advisors, raise your hand. You probably are in the wrong place, because you probably already know this, but this is intended for clinicians. So the why behind healthcare for clinical leaders, that's going to be the first topic. Then we're going to talk about the what, like what do I need to do as a clinical leader as it relates to finance. We're going to talk about strategic roles that clinical leaders play in an organization. And this is going to be split in 2 components, one for managers and directors, and the other one for executives. So if you are a CNO or if you are a CMO, it gives more clarity about what is that strategic role that you play in the organization. We'll talk a little bit about budgeting and capital planning. They are interrelated, but 2 different things that are part of the financial planning. One is for the operating side, the other one is for the securing capital fund. And then your role in driving growth. So we'll talk about how clinical leaders can drive growth, both from a manager and director and also for an executive. And then how to develop strategies to transfer financial knowledge. I mean, I think this is important for clinical leaders, because as you gain knowledge with your experiences, as you get exposed to financial topics, as you get exposed to strategic planning, you will gain some financial acumen, and then you have the responsibility to transfer that knowledge to the next leaders. So how do we do that? We'll talk about that a little bit. I only have 700 slides prepared for this, so we'll try to get it quickly. No, I only have a few slides. I tried to put it in Excel, but it didn't quite fit. So they asked me to put it in PowerPoint. So we are going to go with PowerPoint. Hopefully you guys will be entertained with this. So the why about healthcare finance for clinical leaders. Like, why do we do this? Like, so first, give me some emojis or some reactions about these concepts. Are you familiar with these concepts? CLAPSIs, HAPIs, tempo, HMPs, pressure injuries, safety huddles, environment of care. Do you guys recognize some of those concepts? Can you throw some emojis or something? All right, this is the interactive part. You don't want to do anything else other than put a heart, put a happy face, thumbs up, move around, I don't know, activate your camera. So you should be familiar with these concepts because these concepts live in the clinical space. Most of the clinicians live and breathe these type of concepts, and they are preoccupied on impacting them in one way or another. They want their organizations to become leapfrog A. They want to make sure that they're ready for the Joint Commission. They are always looking at NRC score or patient experience. They are working in Epic all the time. They keep an eye on CLAPSIs, so they minimize the number of CLAPSIs in the year. So they are always in it. And you have, as a leader, as a clinical leader, you have developed a know-how in this space. So there are some other concepts that when we talk about finance, clinical leaders have to become accustomed, or they have to gain the knowledge. So when you read the concepts on the right side, do you have the same level of confidence to speak about a strategic business planning? Can you speak intelligently about your operating budget? Do you feel comfortable about what is a direct margin? What is the CMI, how it gets calculated? Do you know what is an acid test? Can you speak about labor benchmarks? Do you know what are the financial classes in your organization? Do you know what is a stop loss? So these type of concepts are the concepts that you got to get familiarized with. So there is a need to gain a new set of knowledge or new skills. So that's the why. As a clinician now, you wanna explore the finance space, there is a need to develop a new skill. And that skill is the business management aspect of it. So detaching from I'm not saying that you're gonna forget about the bedside or the clinical side of the business, but you need to gain a new knowledge in the business side of things. So there are 4 key principles that are gonna be kind of like the foundation of business management: planning, organizing, leading, and controlling. And finance is going to be prevalent in all those aspects, but especially as it relates to how we plan and how we control. So when you talk about finance, we live in those spaces predominantly. How do we plan this? How do we control it? So as a clinician, you got to develop that skill. And you do it all the time, and the skill exists because clinicians, they're always planning the care of the patient. Clinicians, they're always controlling the outcomes of the patient care. With the same type of approach needs to be applied to finances. Okay. All right, we move on about the why. And so now we'll talk about understanding the key drivers of profitability in healthcare. So there are a few, and they combine. So the payer mix is extremely important. The payer mix in a healthcare organization is vital. We got to make sure that the services that we provide have a means to pay. As a clinician, you usually are agnostic of the patient's payer source. We provide the care regardless of. But when we talk about finances and the drivers of profitability in a healthcare environment, it is important to understand the payer mix of the services. It is a different payer mix if the services are provided to pediatric patients, or it's different if it's provided to women's health, or it's different if it's provided in the ED, different if it is an elective type of procedure. But as a clinician leader, you have the responsibility to understand that payer mix. The better the payer mix, the better chances of obtaining a profitable margin in an organization. The second one is service line optimization. So in your organizations, how do we identify those service lines that are high margin producing? How do we balance the service lines in our portfolio? So think about service line like a stocks. Like I have to have a good spread of stocks where I'm investing. Similar thing, service lines, are offerings, and they all come in different flavors, and they all produce different outcomes from a quality and patient experience type of thing, but also from the economics. Service lines such as cardiology or oncology are high margin type of service lines. So when you balance your portfolio, you want to make sure that you have high margin type of service lines so they can help you subsidize the low margin service lines that you still want to offer. Volume growth is also, the volume is also another key driver of profitability. I always say, volume helps cure all the diseases in healthcare. The higher the volume, the more chances that you're going to have to liquidate your fixed costs. And we are an industry that is traditionally heavy on the fixed costs, heavy on the equipment costs, heavy on the infrastructure costs, heavy on the labor side. So in order to supersede the break-even point, we got to make sure that we attract volume and that the offerings have enough volume to pay for the fixed costs. So the volume is an important driver of profitability in healthcare. So as a clinician, you should be concerned if you have a service line, you open a service and the volume is not ramping up. So you should be concerned because the volume is a key driver of profitability. So that's a learning. The acuity or the CMI, it can also be expressed as an APC in the outpatient setting. It's important. The higher acuity will usually yield higher reimbursement. So maximizing documentation on how we document the care that we provide to yield a better CMI or a different type of APC coding is important. The higher, the better. And then operational efficiencies in labor and in supplies, also important in the cost control. We're trying to minimize and optimize the way how we use our resources. So that's another driver of profitability in healthcare. All right. So this is a little bit more about those drivers, trying to expand a little bit more on that. Patient status, extremely important that as we deliver care, we determine the patient status at the point of admission in the correct way, using medical necessity tools, determining which patient requires to be in an inpatient setting versus an outpatient setting or versus an observation. The length of stay is important because it drives costs. Most organizations, when they have a patient in the house or in the hospital, especially in the inpatient, they get paid a flat rate or a DRG type of reimbursement, most of them. So minimizing the length of stay is important. DRG types, you got to get familiarized with how you get paid. And ask the questions. If you're a clinician and you have a service, you work in rehab, or you work in, in NICU, or you work in surgery. It is completely fine to understand how you get paid. It is your business. You're leading a unit, or you're leading a division, or you're a director of a certain type of clinic. You got to understand. You have to understand how is the company getting paid, because you want to impact that. Some of the types of reimbursements are DRG. You can also be a per case rate. At times, organizations get paid in a % of charges. There is also a per diem or per each day type of reimbursement. And there is also a combination of all of it, where we can get paid blended. So try to understand that. As a clinician, you try to, it's perfectly fine. Grab your CFO or your director of finance and ask them a question. And so that'll be important for you to understand. All right. Expanding on these drivers of profitability, the financial classes or the payer sources is extremely important. Those are the types of, I'm not going to read it, but those are usually the types of classifications that exist for payer types in the industry. Commercial payer, very important, and the impact of the government payments on your reimbursement is also important. But those are the types of classifications. Usually, those are the ones. And we have the exchange also added lately. Operational expenses. So you got to recognize what type of expenses are considered operational. And those are some of the classes that, or the types of expenses that we incur. We talked about acuity, another type of acuity, for example, in the ED, they have their own acuity based on the ED levels. Traumas have levels. NICU type of care can have levels. Another important terms related to these drivers of profitability, you got to get familiarized with what is a capital item in your organization. How does the organization calls something a capital? It is different for my company than the one that I have worked in the past. For example, anything over $5,000 that has a useful life of 3 years or more could be considered capital. In some other organizations, they lower the threshold, and anything that you buy over $2,000 and it has a 2 years of life or greater is considered a capital. So try to get familiarized with that. As a leader, you need to know that. Understand the budget cycle, understand how the income statement looks like, and get a good understanding on the labor management, because in healthcare, about 64% of what we do is labor related. The cost structure is heavily allocated towards the manpower, and labor is a significant component of the financial structure of any healthcare organization. All right. We're gonna continue to move on. And if you have any questions, or if I'm going too quick, just put a comment on the chat, and we will address the question. I mean, we don't want to answer the questions at this moment, but if you have a question that pops, just put it in the chat, and we'll try to address it towards the end. All right. I only have like 300 more slides to go. I knew I needed to put this in Excel. All right. Key drivers of profitability. So I'm going to give you an example in the hospital setting, and so kind of show you how a hospital generates earnings. And it's going to be an example related to an encounter in the inpatient side. So hopefully we have people or attendees that are working in the hospital setting, so these may relate. All right. Okay, so this is an example. We have here 5 patients. All of them share the first name, which is patient, but they have a different last name, which is A, B, C, D, and E. That's a great joke. But so 5 different hypothetical patients here, and they all have the same disease. Same type of DRG or similar type of DRG, and they are all inpatient. So they are in the hospital, or they were in the hospital. So they went and visited the hospital. And they all stay either 5 days, 3 days, or 8 days. So, we have 3 patients that stay in the house for 5 days, 1 that stay 3 days, and 1 that stay 8 days. And then the geometric mean length of stay for the patients, there were 5, except for one of them probably had low acuity. It was 4. So when you look at the excess days, if you look about expectations, we in healthcare, the government is telling us this is the amount of days that the patient should be in the hospital, 5 days or 4 days. And then, so there are 3 patients that met that expectation. They came for sepsis, they stay in the hospital for 5 days, and the expectation is that they were going to stay 5 days in the hospitals. And we have 2 outliers. One of them stayed longer, and the other one stayed for a shorter period of time. So probably got healed sooner or faster. So we have a gain, and then we have another one where we invested more time to care for the patient. So that's the length of stay and the same DRG. And then we have the financial class. So now we are adding the financial class as a driver of profitability in this example. Okay, so two patients have a payer source equal to Medicare. One of them is being paid by Blue Cross. The other one is self-pay. And the last one is Medicaid as a payer source. So that's the financial class, which is another driver of profitability. If you recall the drivers of profitability, payer mix, volume, CMI, cost, right? So when you look at the charges are gonna vary depending upon how long the patient stay in the hospital setting. So if it stay only 3 days, we're gonna charge probably $60,000 in charge. If it stay 8 days, the charges are gonna be larger. In this case, 160,000. For the patients that stay 5 days, you're gonna charge 100,000 probably for it. And this is all hypothetical, but just so you can have context. Now in healthcare, what we charge is not what we collect. It's not like when you go to a restaurant and whatever they charge you is actually what you pay. Plus, you voluntarily give them a tip. It doesn't work that way in healthcare. You get a bill, and we don't get paid what is in the bill. So in the news, as you may recall, there's always cases where they discover that hospital charges are $7-8 million per encounter or whatever. Hospitals don't get paid that. They have contractual arrangements, or they have specific rates already determined by the government that we get paid for. So when we look at the net revenue line, that's the actual reimbursement that the hospital will get paid in these hypothetical cases. So on the Medicare cases, we get $12,000 as a payment for the care. Blue Cross is gonna pay us 3 times that. Self-pay, historically, we get 1% or nothing on self-pay patients. And then Medicaid will pay a portion of Medicare. And then we have another line that calculates the actual reimbursement as a percent of the charge. So 7%, 12%, 36%. It's just the relationship of the reimbursement to the charge. So you can see now that a couple of key learnings before I move on. Patients stay longer, then we're gonna have more charges to it. It's not gonna impact the amount that we get paid. In this case, for example, patients stay 8 days, we're still gonna get paid $12,000. If it stay 5 days, we're still gonna get paid $12,000 if it's a Medicare type of payer. The commercial payers usually pay more. That's a learning. So this is good. And self-pay, we get nothing usually historically. So you're gonna see how this Blue Cross type of patient is gonna play a role in the overall profitability of this case. All right, and then we add the cost. Couple of things to know. The cost is gonna be higher when we review the patient that stay longer. Naturally, if patient stays longer in the house, we're gonna invest more time, more resources to care for that patient. So the labor and the supplies and the drug costs, the first 3 lines, they're gonna flex accordingly to the time the patient stay in the hospital. If it's 8 days, it's gonna be higher. If it's only like 3 days, it's gonna be lower. So you can see that there are savings when we maximize the opportunity on the length of stay. We create savings on the labor. And then we have to absorb all the fixed costs, administrative expenses, professional fee expenses, depreciation, the overhead. So at the end of the day, when we just look at the bottom line, in the patient that stayed 8 days, we lost $5,200. If you would have stayed only 5 days, we would have lost $1,800, like the second patient. In the case of the managed care patient, we actually made some money. On the patient that didn't pay anything, it was a complete loss. The entire cost is what we're losing. We are not getting anything from the revenue. And in the last patient, the loss is higher because the net revenue is actually a fraction of what we get paid from Medicare. So in every instance, we lost money except for the Blue Cross patient. So the Blue Cross patient, the margin from the Blue Cross patient is helping subsidize the losses on the other patients. So at the end of the day, we only generated $4,000 on a $500,000 type of charge. And the percentage of profit was 7%. This is a hypothetical, but in the industry, in healthcare, the margins fluctuate between 1 to 2%. The overall margin of healthcare organizations in the nation is about 1 to 2%. So this is actually optimistic. All right. That's so much for the example. Hopefully you guys got it. We move on about the what about finance. All right, so the what about finance. So I'm a clinical leader. So what do I need to do about these things? I'm a manager, and how do I get? What is exactly what I have to do? I'm not going to tell you how you're going to do it, but I'm telling you what you have to do. The spaces where you need to immerse. So it's broken down in two components: managers and executives. So if you're a manager, you have to develop a really good understanding about your volumes. If you have a department, a unit, or a clinic, or you have a center, you got to understand your volumes, whatever they are. It could be a patient day, it could be a visit, it could be a surgery, it could be a procedure, it could be an infusion, it could be an ED visit, it could be number of deliveries. You got to master that. You got to know your seasonality. You got to know the average volume. You got to know the projections for next year. You got to know your budgeted volume. You got to develop a really good understanding about the volumes. And that's going to be the easy part, because you guys live in that space, in the clinical environment. So this is going to be easy. The first item is going to be that slam dunk. Then you have to develop a good understanding about your hours per unit or your labor standard. Here is where you're probably going to struggle a little bit. And the recipe for success on this one is to leverage your finance division. Don't spend days trying to understand your hours per unit. Call your finance director and say, okay, how was this calculated? What was the benchmark that was used? Explain it to me. Why is this different to me? It is important for you to understand that benchmark, because it will determine your ability to staff. In healthcare, we use standards to estimate number of FTEs or the people that we call in. And these hours per unit of service is the genesis of it. That multiplied times the volume will determine how many hours of labor you're going to need and how many FTEs you're going to get budgeted. So understanding really well and mastering your hours per unit will be vital for you as a manager or a director. Now, understanding if your unit is primarily variable or if it is fixed. And so if it is fixed, you need, for example, quality, the quality department, or a prevention, infection prevention department, finance. Those are fixed units. They don't necessarily fluctuate in accordance to volume, one-to-one. The company has to expand a lot for those units to actually grow. They have a lot of capacity to absorb more work. But if you're talking about a clinic, if you add another provider, or if you add a new chair for infusion, or if you add additional beds, then you start thinking about how many nurses do I need, how many techs do I need, how many unit secretaries do I need transport, is it going to impact imaging? So understand what component of your staffing is variable and what component of your staffing is fixed. That's important. This one is extremely important. The staffing grids. So this is actually the way how you call for the army to come into the workforce. So you have a way and a method to call your people to work when your volumes go up or down. That is your staffing grid usually, or a staffing schedule. You need to understand how you can impact that in the event that your labor expense is getting off track. So this is the space where usually finance will say, hey, your productivity is below 90%. And you as a leader will say, well, how do I fix that? You got to look at the way how you're calling your army, your manpower, your people, your team members, and see, hey, do I have an imperfection here? Am I calling too many team members at once? Do I need to be more cautious about this? You got to adjust the staffing in accordance to the volume. And then, so it's extremely important for you to get develop an expertise in that space as a manager or a director. And then the next one, you got to learn to differentiate what is an expense and what is a capital item. So if you need additional beds, and you need additional ultrasounds, you know, an MRI, you need an expansion of your unit or your clinic, you're talking about capital. You're talking about investment. You're not talking about an operational expense. And that has a different path than an operational expense. An operational expense is usually attached to the normal activities, daily activities of your unit or your organization. The capital is a little more intense, so it has a different path. Learn to understand, what are we talking about? We're talking about expanding the whole building. It is different conversation. Or are we just talking about bringing in additional team members so I can accommodate higher volumes? So different conversations. And as a manager, you need to learn that. And then understand the supply chain management process. Every organization uses a different method and approach to secure supply items and to bring them to the clinicians. But there is a process for it. They do not appear magically. There's a lot of frustration from managers and directors where they show up to their unit and they are like, well, I don't have the supplies to do my job. I don't have the tools and equipment to do my job. Who is in charge to make sure that I got all the supplies that I need for me and my people? But it's usually you, the manager. So as a CEO of that unit, you got to understand the process, like how the supply chain actually delivers these supplies. What is the trigger point? Do I have a power level? What is a power level? Let me understand who impacts the power level. Do I have all the items that I need in a power level? Who is the director of supply chain? When do they show? In the morning, in the afternoon? So as a manager, you got to understand that. It's your responsibility. Understand the process to request education, seminars, consulting. That's the proactive approach that you have to take. And understand the payer mix in your unit. It's important. Now, if you got promoted, then you're no longer a manager. You're no longer a director. Now you're an executive. Congratulations, you got promoted. You don't have to do the above, but you have to keep an eye on it. So the activities change a little bit. Priorities are, for example, you got to identify what are the profitable and unprofitable services and the relationships in between. So you got to know what they are. What type of service lines do I have that are not generating margin, and the ones that are profitable. And then the most important part, determine a plan to improve profitability. Do I need more volume? And how do I achieve that growth? Do I need to control expenses? Or do I need to do a combination of both? As an executive, there's a little more high elevated type of thinking that you have to do there, because those have implications, but that's the activity. Then monitor the denials, the write-offs, the days in AR, because they have an impact on your cash. Similar to the managers, continue to understand the payer mix and the reimbursement rules. And then as an executive, you got to increase the cash position of the organization, and you got to manage the debt to asset ratio. So it's important. We cannot forget that cash is king in healthcare. When we have a 1% to 2% margin in the industry, the ability to capitalize on the cash is extremely important. You have a lot of cushion there. So cash is king. Make sure that you validate what is your cash position and then try to increase that cash position. All right. The strategic roles. How am I doing with time, Bruce?
Let's say you got about maybe 30 minutes till
Okay.
1:10.
Okay. All right.
Going good.
You shake the bones a little bit. Whew. It's a lot of PowerPoint. We need an Excel file. On the next one, we need to do an Excel file for this one. All right, strategic roles and context. So for managers, what is your strategic role as it relates to finance? So you got to make sure that you align whatever clinical proposals that you have in the unit level, that those are aligned, and that you have goals and metrics. And you got to check if projects that you have are supporting or are in alignment with the division priorities. So it's all about aligning. Whatever you're doing as a manager in your department, it is aligned with the strategic plan. And for an executive, You got to ensure that that strategic alignment exists for all departments. So make sure that there is an integration with every department. If you're an executive, every department, imaging, lab, pharmacy, surgery, everyone is actually integrated and aligned, and that alignment drives your strategic objectives. And you have to support and evaluate cross-departmental plans with enterprise-wide values. So easy to say, but hard to execute. That's the strategic role the executives play in an organization. Okay, this is fine. Budgeting and capital planning. All right. So for managers and directors, so when we talk about budget, let's understand that budgeting is a planning, it's an estimation. There is no organization that actually hits 100% of their budget by year end. We estimate, do our best thinking, we put a target, and then 100% of the time, companies supersede the target or they underperform. But they actually rarely hit it like to the dot, because it's a plan, it's an estimation. It has a level of failure there. We do our best to estimate performance, but once the ball starts moving, companies usually exceed it or underperform. So remember, it's an estimation, but it's extremely important because it drives a lot of the planning. So for a manager, budget preparation is about timing and the planning, like I said. You got to know when the budget requests are due, and then you got to plan ahead. Many clinicians forget about that there is a budget session. So if you're a new leader, you're a new manager or a new director, find out, okay, when do we start budget? Because I want to put my requests from the get-go, or I want to have the conversations early on about my needs. So timing is important. If you react, so say, for example, you don't ask, and then the budget gets produced, and you say, hey, this budget is wrong. This is completely wrong. Whoever did this this is garbage. And you try to impact it, impossible. Once the budget is sealed, you just got to live with it for an entire year. And you don't want that. So as a manager and as a director, identify when the budget process starts. And there are usually finance leaders in the organization that can provide support. So try to identify who those individuals are. They probably look like me. They're bald and short. So that should be an easy way to locate them. Start with the volume assessment. So when you do your budgets for your units, start with the volume assessment, because the volume will drive the staffing needs, it will drive the supply needs, and then do a zero-based budget. This is a recommendation for all other lines of expense, such as seminars, purchase services, service contracts, depreciation. And when you do this, organizations provide support, so you don't do it on your own. There is an arm or a division of finance or financial planning that helps with elaboration of the finance of the budget for the organization. So you're going to have support. Remember that everything starts with the volume. And then when you ask for more, use clear metrics and have justifications for your request. If you're trying to add a supervisor, or you're trying to add a unit secretary or a new clerk, make sure you have justifications for it and metrics that support it. And then again, identify capital needs for your department early in the process, and coordinate the capital request early in the process. Capital is not abundant in healthcare, so it's actually limited. So the sooner that you put the request, the more chances that you have to get an approval. And the sooner that you make your business case to secure capital, the better chances that you have to secure it. So that's for managing director. And then be ready to pivot. In finance, the budget process, the way it works is we take all the requests, we put into a machine, and it gives us a result that we don't like, and we put it back. Say, for example, we accumulate all the requests from the clinicians, and it generates a loss of, I don't know, $1 trillion. Okay, this is not going to work. Go back and say, you got to adjust. So be ready to pivot to a reasonable extent. Be ready to pivot. That's going to be asked from you. For executives, so if you got promoted, congratulations, you're an executive. Same thing, timing. Use the timing to drive resource alignment. So you have the responsibility to shape the budgeting calendar now. So you're going to drive it and advocate for key initiatives early on. If you want to deploy a new service line, you want to expand into a new, say, for example, you want to become a trauma type of facility, or you want to become an EQ level, whatever, 2, 3, 1. Start early on and start advocating and gaining support for it. Be present, participate in the annual planning phases. So this is common where, I'm an executive, I don't need to show up, somebody else is going to do it. But your presence is extremely important. You're going to be in tune as to what's happening, the requirements, the constraints. So participate in the annual planning process. And then set expectations for financial discipline across your teams. Once you have the objectives, make sure that everyone abides by them. Initiate the discussions related to capital early on and identify the timing. And similar to a manager, get ready to pivot, because most likely, although we put all this work, at the end of the day, when the budget starts taking shape, we may need to adjust and we may need to go back to the drawing board. So for executives, similar that for managers or for directors, be ready to pivot. Okay, our roles, well, actually not our roles, it's your role in driving growth for managers and directors. So you got to drive local service innovation and improvements. That's part of the growth journey. Identify champions identifying and champion opportunities for growth in clinical units. Support well-prepared service expansion proposals with clear data, and identify many improvements that generate capacity, such as length of stay or throughput initiatives. Those are always good because you will create room for additional volume. For executives, you got to oversee the service strategy for your organization. And you got to drive innovation similar to the managers, but it's going to be across the departments. And you got to prioritize. And you got to develop long-term service line strategies. So this is not about, as an executive, you have to have those long lenses, with a long view of the strategy. So develop a long-term service line strategy. And then you got to align those financial goals with that strategy. Make sure that we can pay for it in the long term. And then you got to innovate to exceed growth targets. So you're going to get a target as an executive. Well, I mean, we all do. And then the idea is not to hit the target, to supersede the target. So you got to get it. You got to beat the target. Then you got to innovate for that in order to get that. Okay, this is a quick example as to how we draft, say, a business case or a kind of like a budget planning or a new pro forma for a new program. Sort of the steps as to how we go about it. So an example. So here you go. Step one. Say for example, we're gonna open a new outpatient program. We gotta assess them. Step number one is to assess the clinical need. Is there a need in the market? You got to pull market data and assess if there is a need for it. And is that need an opportunity? There may be a need, but it's not necessarily an opportunity. And then also question like, okay, there is volume. Like, how are we going to get that volume? What is the source that is going to canalize that volume to us? Step number one. Let's start with the volume. Not all the market opportunities can be transformed into volume if you cannot attract that volume. Step number two, identify the requirements in all aspects of the service offerings. In this case, it's an outpatient program. So what are the needs? Do I need a space? Do I need a provider? How many providers? What is the staffing for those providers, hours of operations? what related services I'm going to need. I'm going to need lab. Am I going to need pharmacy? What am I going to need? Imaging. And then with all that, you're going to package the capital needs. After you have acquired all that, you have to partner with finance, because with that information, finance can actually produce a pro forma for you. Don't try to do the pro forma on your own. You're a clinician, you have different level of expertise, but gather the information and then partner with finance and put their fingerprints in the crime. They have to do the pro forma. Give them all what you have, and they have to do the pro forma. They are there to support you. Most of the organizations have a finance division, and their job is to support you with whatever idea you have, as crazy as it can be. It can be a great idea, it can be a bad idea. They have the responsibility to produce a pro forma with the information that you provide, and collaborate with you to see if, in fact, there is an opportunity or not. But do your part. Don't jump from step 1 to step 3. You got to go step 2. You have the responsibility as a leader, if you're trying to advocate for a new program, to gather that information. So that is ammunition for finance to produce the pro forma and the business case. And then in step 4, you start preparing a business case presentation, which is more than the pro forma or the estimated financial results of the initiative. The business case will include the market analysis. It will include the alignment with the strategic plan. It will include the pro forma. So it's more than just a pro forma. Step 5, you have to gain support and start presenting the business case and gain support. And then be ready to pivot, because people are going to have a different type of feedback, and they may need to pivot and go back to step 3 or step 2. And then after all is done and everything has been purified and you have a good business case, then you secure approval and you go for funding. And the last step, make it happen. So you got to deploy. All right. That was the example as to how we do some sort of operating and capital planning in a really small version of it. That's the thinking or the approach. Okay, so this is item number 4 in our agenda, working to promote financial stewardship on the unit. So for managers, we need to make sure that we manage the labor up and down in accordance to the volume. We talked a little bit about this. You have the responsibility to promote financial stewardship in the unit by doing that. Keep your team members accountable. Accountability is important for time and attendance, for missed meals or tardiness. It's not a pleasant part of the job, but you have to do it. It goes back into that control aspect of the business management. And then participate in productivity meetings with finance. Most of the leaders prioritize their safety huddles or CLAPSI meetings, right, for example, or rounding with employees. Extremely important, very important activity. And patient care. Making sure that you have those people able to work in your unit is also important. And the productivity meetings are that environment where if you don't participate, you may not get the resources that you need. So promoting financial stewardship as a manager or director requires you to participate in the productivity meetings with finance, and it will serve you as a leader because you will get knowledge about a space that you're not familiar. Make sure that you run with your team members. That's also important. Because you're going to discover waste, for example. Many times through rounding, you discover waste or opportunities for growth. Team members have great ideas to grow the business. Then validate your census and make sure that you get credit for your volumes. Minimize waste and supplies and any other resources that you have. Make sure that you are a good steward. For executives, this is related to the strategic planning. So ensure that strategic plan deploys as planned. That's part of being a good steward. Don't procrastinate on the deployment. Monitor the growth plan and make adjustments along the way. That's part of what you have to do. And ensure that your leaders understand their role in the plan. So that they have to be in alignment. and accountability. Keep the leaders accountable and round on your leaders, similar to what the manager or director have to do. You got to make sure they have a continuous way to connect with the team members. All right, we are approaching the end, I think. Transferring finance knowledge. So after you do all that, what we just talked, and you have become a very well-versed in finance topics, then you have a responsibility to transfer that knowledge to the next generation. If you have a mentee, if you have a supervisor, if you have an A&M, and you don't want them to go through the pain that you went to learn about finance, to experience issues with your productivity, then after you have matured in your financial acumen, you got the responsibility to transfer that knowledge to the next generation. How do you do that? So you have to identify team members that have the potential to learn, and you got to mentor those team leads. You got to host department level finance check-ins, and you got to invite your CFO, your director, your manager of finance. Just let them come and share their expertise. And then for executives, you got to develop a system-wide financial learning initiatives for clinical leaders. So this is more about the integration and making sure that everyone has a system to learn these financial topics. And then model fiscal accountability and ensure upward and downward finance education. So we all have an opportunity to learn, but you got to design that model and then the accountability related to that. Couple of tools to support the knowledge sharing, like how do we share this finance knowledge? So you got to make sure that you capitalize on those quick reference guides that you get from finance. You got to have a method or an approach to onboard clinical leaders, and as part of that, insert finance topics. You can do launch and learns with your finance buddies, and then, like I mentioned, formal finance onboarding process. Send them to finance. You tell them, hey, you're a new manager, go to finance, spend 3 hours with them, 2 hours with them, find out all what you need to know about your unit and our finances. Perfectly fine. Define an approach for that. Those are tools as to how you can support the knowledge sharing. All right. Summary and key takeaways. So this is the one pager, I guess, of the presentation. So number one, you got to partner with finance and you got to ask questions. Recognize that this is a new space. You got to develop a new skill. So ask the questions. You got to know what the financial drivers in healthcare are, and you already know that. Payer mix, the volumes, CMI, the acuity. So we talked about that, and cost controls. Use strategic and budget timelines wisely. So don't fall asleep. Recognize as a clinician, when is this budget thing happening, and get busy. Support and teach future clinical leaders. That's our responsibility. Take ownership on the finance aspect of your business. So don't procrastinate. Don't assume that somebody else is going to take care of your financial problem. Don't make that assumption. It's yours to solve, to take ownership. And then maintain a positive mindset about the finance space. Don't assume that we work with numbers. You work with numbers every day. There's a myth that clinicians cannot understand these financial topics. I mean, that is not. It has not been my experience. So that's a myth. Get busy and invest time to learn the space. All right. So now we're gonna be open for questions and answers, and that's needed because I've been talking for about almost an hour. So, and if you have any questions, concerns, or desires, please ask Jennifer Justi. We make sure to answer those questions.
Thanks, Felix. Jen, are you there? Looks like we've got a lot of questions in chat already. And Felix, I know that's tough to do a presentation like that when you don't have any feedback in front of you. So thanks for doing that.
Yeah, we've got some great questions. First of all, Felix, let me just say, I wish I had your presentation when I was a clinician making that transition to leader or from leader to executive, you've just given some really fundamental and practical advice today. So I love it. And we do have some good questions. I'm going to start reading some from the chat. If folks want to ask their question verbally, feel free to raise your hand and I'll call on folks that do that as well. So let's see. The first one that I have here is from Dr. John Johnson. And he asked, should we also include payer contract rates and terms separately from payer mix? So kind of going back to the beginning of your presentation there.
Yeah.
Thanks, Jennifer. Yeah. So when I saw that, in my mind, I think of payer mix very different than contract rates and terms. So the mix, like you said, Medicare, Medicaid, commercial, self-pay, that makes sense. But then when you nuance Medicare, Medicaid, and then particularly commercial, the term of your contract and the rates significantly impact the reimbursement amounts and how that contract is structured, if it's a percentage of billed charges versus a flat agreed rate. So I wanted you to just comment on how that fits within your construct of your slide. Thank you.
Yeah.
Awesome presentation, by the way, Felix.
Oh, thank you, Dr. Johnson. Appreciate that. We'll send you a check in the mail. 3 business days.
Yeah, by the way, I think we met at the ACHE in Chicago. I think we sat next to each other accidentally.
Oh,
I didn't know you were at WellStar. We just happened to sit next to each other. That was my first conference.
Good.
And so I was excited to see you were presenting today. So please continue with your answer.
Great, of course. So when we talk about payer mix, the assumption is that commercial line item is the space where organizations have the opportunity to negotiate their rates. So the payer mix structure is usually commercial, Medicare, Medicaid, HIE, other, and then self-pay. That commercial line that you're talking about is the space where the contracting negotiation lives and where we can make an impact on those reimbursement rates. So it is embedded into the payer mix, assuming that all healthcare organizations have the leverage to impact that. Yes, so you're correct.
Thank you. Thank you.
My pleasure.
Great question. Next from Bryant Cornett, he asks, what does it look like to tactically advocate for key initiatives? So, you were talking and even gave a great example of that budgeting process, but, can you give an example of what a really successful advocacy campaign might look like when you're looking to get a key initiative approved?
Yeah. So I think it's important to recognize that for a key initiative, you need to have key players behind the initiative. So gaining support and alignment is important. So tactically, how it looks like is like I walk into like I explained in my example, identify the requirements for these key initiatives, what they are. Partner with finance to produce a pro forma. If it is viable, so the performance is profitable, you're going to gain a lot of support. Now, if it's not, but it's necessary to address a community need, or is necessary for a long-term, long-term expansion, you may have some resistance. Or if the initiative is awesome, but it requires a lot of capital, like very capital intensive. So for example, you're advocating for a new tower. Yeah, it is a $300-400 million initiative. So in that case, you have to make sure that you align all the stakeholders first and go slowly, and make sure that you deploy slowly on that. I had an experience with we were onboarding a bunch of multiple surgeons. We had a plan to onboard multiple surgeons over the next 3-4 years, and I needed to expand my ORs. So I was projecting, hey, I want to need 7 more ORs in the next 5 years somehow. If these providers deploy, we actually hire them, we are going to need. So, and this is a need that I'm going to have 5 years from now. So, but I know the plan, my strategic plan. So I put together a pro forma. I partnered with my COO. We got support from system surgery service line. We put together a package, and we went and asked for the money related to these 5 ORs 5 years in advance. And we got the support, and we have plenty of time to advocate for it. And it got embedded into the 5-year capital plan, and we got it. So alignment and gaining support is extremely important, is key. And then timing, you got to do it ahead of time. Don't do it last minute, because then it's going to look bad on you, and it's going to look like a desperate move. Yep.
Thank you so much. I'm going to jump around a little bit in the questions, but I think we're going to have time to get to everybody. But I wanted to highlight this one from Carolyn Smith. And again, if you want to come off mute, feel free. But Carolyn asked, what are reliable and recognized sources that you recommend to obtain market data regarding clinical need for a proposed service?
Yeah, we use SG2. I think it is here a WellStar, and it's been a very reliable source of information. And you also have internal data. Also trust on your internal data. GHA is also, they also have good data. Most of the hospitals report to the Georgia Hospital Association. They report their data, so you can get an insight of the number of discharges on their primary service area, and you can make a market assessment. But data can be purchased too. Organizations purchase data. So don't try to solve that on your own. If you're part of a large organization, the organization is probably purchasing data to understand and do market analysis. So identify who is who within your system and tap. Now, if you're a small organization, then you have to leverage, SG2 partners with certain software companies, or GHA. That's another good source of information.
Very good. Thank you. Let's see. Next up from Jessica Duke. What is the optimal range of reimbursement % of charges?
No optimal rate. There's no optimal rate. So let me elaborate on that. So healthcare organizations determine their charge structure, and they are not aligned. So I could be charging, they're in the ballpark, but they're not necessarily aligned. So I could be charging, say, for example, $5,000 for an MRI. That would be my charge. But I get paid $500. So a 10% PCR. And I'll say, oh, no, I'm happy with the $500. Another organization may be charging $1,000 for that procedure, and their reimbursement is also $500. So their PCR, or the percent of charges, will be 50%, and they'll be fine. They're both making the same amount, $500 per. So the PCR is all relative to the organization, because it depends about how they design their charge structure. What is important is to determine what level of net revenue you generate and the percentage of expense from the net revenue. So whatever you're collecting, then you look at the expense line and say, how much am I spending? Do I need to increase my volume? Do I need to reduce the expense to generate the margin? So you got to go from the bottom to the top, like the margin that you need, the expense structure, to tie into the revenue, instead of trying to impact that. Because you're trying to optimize that when you have opportunity underneath on the expense side. But there is no optimal, really. It depends about how we charge.
And your negotiating power with the payer.
Correct. Yeah, I mean that leverage. The larger the organization that is, the more negotiating power you have with the commercial payers. That's hands down, and that's why we have so much acquisition in the market, mergers and acquisition in the market. They're trying to get muscle. Mm-hmm.
All right. Carolyn Smith had another question here, and she asks, where does reimbursement for exchange members rank in reimbursement %?
Can you elaborate on that? Is it Carolyn?
Yeah, Carolyn, can you come off mute?
Yeah, you had just referred to when you mentioned that went through the list of payers at the beginning, you just mentioned, and there's the exchange, but you didn't go into the details. It was just a question.
Yeah, so from a payer mix, it is not a large payer at the moment, but it's growing from a volume perspective. And from a reimbursement, their rates are a little bit better than Medicaid, but not quite like a commercial payer.
Thank you. That helps.
Great, thank you. All right. Ainsley's question, I just love. Why are clinicians usually afraid of the finance aspect of healthcare? Why is finance so scary? And I'll just first say, probably if we asked Felix to go put in an IV or do a CT scan, he might feel that's a little scary too.
Yeah.
But Felix, what have people shared with you in the past? Why is it so challenging for us clinicians to kind of get over that hurdle and embrace the world of finance?
Yeah, I think it's just a myth and an idea that the subjects and the topics that we work on a daily basis in finance is completely strange or different or very different than what the clinicians use on a daily basis. But finance in healthcare uses data generated by the clinicians. You know, we analyze the work and the labor hours that they work. We review the codes or the reimbursement on the patients that they see. And we get the penalties for things that happen in the care space. So it's just I guess it comes from a myth. The other one that is very common is that, you know, they always say, hey, you know, I'm afraid to ask you because I'm not good with numbers, which is false. You know, you guys review vitals, which comes in number fashion every day. You review diagnoses that are numbers, and then you memorize doses related to pharmacy and can spot when something is bad or not in the air. Those are numbers. So it's just that they different kind of numbers that you look than the ones that we do. I think it's just a myth. The good thing about it is that finance leaders are usually very amicable and approachable. So that is also a key factor. But it's just a myth, I think, Jen. I had the best experience with the clinicians. Once you start engaging and immersing into that space, it comes actually very easy for some of the clinicians.
Thank you for that. I don't see any other questions. I actually have a couple of questions that I jotted down during the presentation. But if others do, please come off mute and jump into the conversation. I don't see anybody right at this.
If I could
go
make
ahead.
one comment, Felix,
Yeah.
back
Yes.
to the reimbursement question, and I think this is really important, particularly for those of us in Atlanta. When you look at the ACGME hospitals that teach, typically teaching institutions are authorized to get a higher percentage of billed charges because of their teaching activity through CMS. If you could comment on that for those that are at teaching hospitals versus those that are not, how they're made whole relative to their teaching activity and in their rates.
Yeah, so you're correct. I mean, teaching facilities, which are few, they get an additional type of payment related to their residents. So there is an equation as to how much labor intense they are in the resident space, because these facilities are incurring an additional cost to teach these new providers. So that additional cost is not covered by the regular DRG reimbursement that is allocated to Medicare patients in the industry. So they get an add-on to it. And then the intent of that add-on is to make them whole for the fact that they are investing on the new clinicians, on the new residents. So yeah, you're correct. I mean, that's is unique, and then the government tried to make it right by adding a compensation rate to those facilities, to those teaching facilities.
Thank you. Thank you, Felix. Thank you.
Good call out, yeah.
All right, well, we're waiting for folks to think of any other questions they might have. I wanted to touch on one thing. You mentioned how important it is to understand your supply chain process. And, you know, as a clinical leader, it took me a long time to understand why, you know, our supply chain leaders and finance really wanted us to use those preferred and approved supplies versus special ordering all kinds of, you know, things that might be a personal preference. Do you want to speak a little bit to the impact that can have on one's budget?
Yeah, certainly. Yeah. So good question. I think that question relates to the need to standardize and supplies and the utilization of those supplies. There is a benefit when we standardize the use of supplies. We can negotiate better payment terms, better pricing when we standardize the supplies. We can also predict better the way how we secure the supplies for the units. It is easier to procure, easier to manage, easier to inventory, to keep an inventory. It makes things predictable. So when you have, as a clinician, say, for example, you don't like the product that the company is providing, and you're trying to explore a different product, then supply chain has to create a different code for that, a different part level for that. It has to do a different ordering for that, secure different pricing for that. So there is economies of scale that need to be maximized, and then so that's one component. But also the predictability, how we predict the supply chain process for the clinicians, and how we position ourselves in a better place to secure the devices that you need in the unit is also a benefit when we standardize. So the standardization is related to the standardization of supply chain devices.
Great, thank you for explaining that. Another question I had, you know, when you were talking about key drivers of profitability, you mentioned geometric mean average length of stay, and that can be kind of a tough concept to understand. Could you give maybe a basic description of how that's different from just average length of stay?
Yeah, so the geometric mean average length of stay, it is a estimated length of stay that is given by CMS to a specific diagnosis or diagnosis group, where CMS is saying for this specific type of disease, it is expected for the patient to stay X amount of days in the hospital setting. So we have that metric for every diagnosis in that is expected for a patient. And then we sort of compare that geometric mean length of stay given by each GRD to the actual performance. We come out with a blended geometric mean average length of stay for the organization. It's very hard to attain because it is determined by CMS by looking at the top tier performing hospitals on length of stay, and they come up with a standard. It's basically the standard from CMS for length of stay for a disease.
Thank you.
Yeah.
All right. If no one else has questions, my last question for Felix, knowing that at least some of our audience today might be studying to take the Board of Governors exam for their fellow, for their FACHE, any advice that you'd have in terms of preparing for the exam in general, or specifically the finance portion of the exam?
Yeah, I did put it in the appendix. Good question. For those that are pursuing the FACHE credentialing and are going to go through the Board of Governors exam, remember 12% of the questions is related to finance, not a lot. These are some of the topics that you potentially will get asked. But the tip of the day, if you're preparing for the exam, is learn about ratios. So the ratios in healthcare are basically a percentage. That's what it is. The fraction is a percentage. And finance attempts to identify the economic viability of an organization or the financial performance by using these ratios. Tries to determine how prepared the organization is to face their financial responsibilities in the short term and in the long term by using ratios. And there is a variety of ratios. But so there is, try to learn about ratios because probably you're gonna get asked. There are a couple of sample questions here about ratios. I selected like 4. So in the first one, for example, the question may come in this fashion. Temporary working capital should be financed through, and then it gives you a couple of options. So when reviewing this type of question, the key word there is temporary and working capital. So it's a temporary, it's a short term. So are you gonna lease something when you have a temporary need? You probably won't. Are you gonna ask for stakeholders to invest money when you're gonna have a temporary need? You probably won't. Are you gonna use your receivables? You could. You could also use short-term debt. So short-term debt is the correct answer. Although accounts receivable could be also a good answer because you can actually sell it or collect. The thing about this is that it's gonna be a best fit answer, and then you gotta align in this specific case the need with the financing. On the second one is very similar. We talked about which of the following classifications of group of financial ratios would be the most useful as a guide for a long-term financial viability. So you're talking about long-term. And then, so out of the get-go, option B, which is short-term debt, you will never finance, a short-term, long-term venture with a short-term debt. So C is out of the question. Accounts receivable is a short-term, is a liquid asset. So option D is gone, and then you have leasing and equity financing. So equity financing will be the one because we're talking about long-term and not necessarily the leasing of equipment. Now, leasing of equipment is more like a midterm. It can go to 0 to 5 days, but we're talking about long-term. So these are some of the questions that you can get asked during the exam. It's going to come in this fashion, but my tip of the day for those that are preparing is review the ratio portion of the VOG, because that's at least 6-7 questions are going to come, I assume, from that space. All right.
Great advice. Thank you, Felix. And we've gotten lots of thank yous, and everybody was really impressed with your presentation. So thank you again for your time today. Bruce, I'll hand it back over to you.
Thanks. Thanks, Jen. And thanks, Felix. What a great session today. And like Jen said, the comments in the chat are awesome. So everyone really appreciates your presentation. So thanks for doing that. And Jen and Ainsley, thanks for organizing today's session. Great job. And thank you to our sponsors. We sure appreciate all you do to provide leadership to the healthcare industry in Georgia. And just as a reminder, be sure to complete the meeting evaluation that I'm going to email to you later today. That's also going to include the slide deck from today, because Felix had a lot of info. I know it's impossible to try to keep up with notes for all that, but you'll have a slide deck and the recording of today's session too. Be sure to self-report 1.5 hours of qualifying education credit on the ACHE website. There's in the My ACHE section over there on the right-hand side, there's a place, I think it's education credit, and you can go there and claim your credit. I think that's it for today. So I hope everyone has a great day, a great week, and thanks again.
Thank you all for attending.
Thank
Bye-bye.
you. Appreciate it. Bye.
Have a good one.
Thank you.
Bye-bye.
Thank
Bye-bye.
you. Bye.